All right, welcome. We're going to run through a simulated consultant-level viva exam focusing on a really complex abdominal trauma case. I'll be your examiner. Let's go ahead and begin.
Right, so here's your scenario. A 35-year-old man, high-speed car crash. He's tachycardic, he's hypotensive. The ambulance is minutes away. Talk me through your approach, starting right now.
Okay, a structured approach is absolutely critical here. It's what keeps you from missing things in the chaos. So I'll follow this progression. We'll start in the trauma bay, then move to the initial assessment and resuscitation. From there, we'll get into the OR for diagnosis and grading the injuries, then talk through the operative strategy itself. And finally, we'll cover post-op care and then just review the really high yield points from this case.
Very well. Let's start with your immediate priorities. The patient is literally being wheeled through the doors of the trauma bay. What are you doing?
My approach is going to be strictly by the book. Advanced Trauma Life Support, ATLS. It's all about finding and fixing what will kill the patient first. So I'll start with A for airway, making sure it's clear while someone holds C-spine. Right into B for breathing, checking for equal breath sounds, making sure he doesn't have a tension pneumothorax. Then C for circulation, which is going to be huge for this patient. He's hypotensive, so we're getting 2 large-bore IVs in, drawing bloods and starting fluids, all while my team is looking for any obvious external bleeding. After that, a quick D for disability, a GCS score, and finally E for exposure. We need to get all of his clothes off to see everything, but we've got to keep him warm to prevent hypothermia. This primary survey has to be fast, it has to be smooth, and it has to be systematic.
Good. You're working through the primary survey, you've given an initial fluid bolus, but he remains unstable. His abdomen is getting more distended and it's tender. What's your key adjunct at this point?
Okay, this is it. This is a critical decision point. Your fast scan, the ultrasound, shows free fluid in his abdomen. He's still hypotensive despite you pouring fluids into him. What is the one, single, definitive next step you need to take right now?
Emergency laparotomy. There is no other answer. And this is a major teaching point. A hemodynamically unstable trauma patient with a positive fast scan goes straight to the operating room. There is absolutely positively no role for a CT scan here. Taking the time to go to the scanner would be a fatal delay. The diagnosis is clear enough. He has life-threatening internal bleeding, and the only treatment is to open his abdomen and stop it.
You've made the correct call. You're in the OR. You've made the midline incision. You've entered the abdomen, and it is full of blood. Just a massive hemoperitoneum. After you get some packs in and suction out the initial gush, you find the spleen is bleeding heavily. Let's talk about grading these injuries. Okay, what I'm seeing is a deep tear that goes right into the hilum of the spleen, where the main blood vessels are. It's bleeding actively from those vessels. According to the AAST scale, that's a grade 4 injury. Now here's the key part. In a stable patient, a grade 4 might make you consider other options like angiography. But in this patient, who's unstable, the grade just confirms the severity. His physiology has already made the decision for me. The spleen has to come out. It's a splenectomy. But knowing the grades is still vital for clear communication and for managing stable patients. After I get control of the spleen, my next step is a systematic exploration of the whole abdomen. And what I find is a large hematoma right in the middle of the retroperitoneum, over the pancreas and duodenum. I also see some bile staining. These are massive red flags. This is a classic surgical principle. A central, or zone 1, retroperitoneal hematoma must be explored. To do that properly, I have to perform a full Kocher maneuver to lift the duodenum, and a Cattell-Brasch maneuver to mobilize the entire right side of the colon. Only then can I actually see what's going on back there.
Excellent. Your exploration reveals the full, devastating extent of the damage. You've got the grade 4 spleen, a complex duodenal injury that involves about 75% of its circumference, a completely transected pancreatic neck, and a destructive injury to the right colon. This is a true nightmare scenario. Prioritize and walk me through your management plan.
My priorities here are simple. Stop the bleeding and stop the contamination. So, first, splenectomy. That takes care of the most immediate life threat. Next, I'll tackle the pancreas. A complete transection at the neck is a grade 3 injury. The standard of care for that is a distal pancreatectomy. So I'll resect the body and tail of the pancreas, and then very carefully oversew or staple the remaining pancreatic stump. And placing drains near that stump is non-negotiable. You have to anticipate and manage the pancreatic leak that's almost certain to happen.
Okay, now for that duodenum. This is a really tough injury. A simple repair is probably not going to work. This is where your knowledge of advanced techniques comes in.
What are the possibilities here?
For an injury this bad, a simple primary repair is just asking for a leak. My first choice would be to carefully trim the edges back to healthy tissue and then do a meticulous primary repair, reinforcing it with a patch of omentum. But you have to be honest with yourself. With the pancreatic injury and the patient's unstable condition, that repair is incredibly fragile, so I have to be ready to perform a pyloric exclusion. That's where you close off the pylorus and create a gastrojejunostomy to divert all the stomach contents away from the duodenum. It's a critical bailout procedure that gives my tenuous repair the best shot at healing.
And finally, we have that destructive right colon injury. Now, the way you manage colon trauma really depends on two things: where the injury is and how sick the patient is. For a right-sided injury like this, the standard of care is a right colectomy followed by a primary ileocolic anastomosis, meaning we hook the small bowel back up to the colon. The blood supply is great on that side and the stool is liquid, so it's generally safe. Now, if this had been a left-sided injury in the same shocked patient, the risk of that anastomosis leaking would be way too high. In that case, the much safer move would be to resect the injury and create an end colostomy, also known as a Hartmann's procedure.
You've navigated an incredibly complex operation. The patient is now closed and on his way to the ICU. The surgery might be over, but the fight is far from it. Let's talk about the postoperative management and the pitfalls you need to look out for.
A critical and very frequently tested part of post-splenectomy care is preventing what we call overwhelming post-splenectomy infection, or OPS. It's a devastating, often fatal sepsis from encapsulated bacteria. So it is absolutely mandatory that this patient gets vaccinated against Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza type B. Ideally, we give these about 2 weeks after surgery to make sure his immune system can actually mount a good response. This is a core knowledge point you just can't afford to miss.
A good surgeon is always thinking ahead. Given all the repairs you did and how sick this patient was, what is the one complication that you're going to be most vigilant for in the next few days?
My number one concern, without a doubt, is an anastomotic leak from where I connected his small bowel to his colon. And the reason is simple. His initial shock and the massive amount of blood transfusion he required are huge, independent risk factors for a suture line to fall apart. That means that even if my anastomosis was technically perfect, it's at a very high risk of failing in this specific patient. I'll be watching him like a hawk for any sign of sepsis, a fever, high heart rate, any hint that things are going wrong inside.
Very good. You've shown a clear, systematic approach to a very messy problem. Let's just take a moment to summarize the critical principles that this case has really hammered home.
To recap, managing this case really came down to a few key principles. First, sticking to ATLS. Shock plus a positive FAST equals an immediate trip to the OR. Second, having clear priorities in the operating room. Stopping the bleeding and contamination always comes before fancy repairs. Third, recognizing surgical red flags. A central hematoma is a must-explore situation. Fourth, and this is a big one, tailoring the operation to the patient's physiology, not just the anatomy. And finally, thinking beyond the operation itself and remembering critical post-op care, like those splenectomy vaccinations.
Excellent. That was a thorough discussion. One last question for you. It's 2 o'clock in the morning. Of all the things that could go wrong with this patient, what is the single physiological factor you're most concerned about tonight in the next 12 hours? Think about that lethal triad of trauma: coagulopathy, acidosis, and hypothermia. Which of these and its ongoing effects poses the most immediate threat to his life right now? That's something to really reflect on.